Welcome to this lecture on somatoform and conversion disorders and their relevance in EMS. Today, we'll briefly remind ourselves of the mind body connection and then dive into what somatoform disorders are. We'll cover key definitions, including conversion disorder and illness anxiety disorder, and focus on how patients with these conditions may present in the pre-hospital setting. These disorders cause very real symptoms from psychological origins, so it's crucial for us as EMS professionals to approach such patients with knowledge and compassion. Let's get started. First, let's reinforce the mind body connection. We know from experience that psychological factors can cause very real physical symptoms. For example, severe anxiety might cause chest pain, shortness of breath, or even make someone feel numb or faint. These are called psychosomatic symptoms. Psyche, meaning mind, and soma, meaning body. It's the body's way of reacting to emotional or mental stress. In emergency care, we see this often. In fact, functional or somatic symptom presentations are frequently encountered in ERs and EMS. You might respond to a 911 call for chest pain or seizures, and after all tests, find no organic cause. The cause could be stress or another mental health issue. Nearly half of patients who rush to the emergency room for chest pain find out it wasn't a heart attack. Of those, about 30 to 40% learn that anxiety was the culprit. So, the mind body connection is not some abstract concept, it's something we run into regularly. As EMS providers, we must keep this link in mind. When a patient's symptoms don't add up medically, consider a psychological origin once you've ensured it's nothing immediately life-threatening. This mindset will help us provide appropriate care without missing a serious condition. Now, let's define somatoform disorders, also known in DSM-5 as somatic symptom and related disorders. These are a group of conditions where a person has very real physical symptoms, but no organic or medical explanation can be found for those symptoms. In other words, lab tests, imaging, and exams often come back normal despite the patient's complaints. Crucially, the patient is not making it up or faking these symptoms. The pain, weakness, or other issues they feel are genuine to them. They're just coming from psychological factors rather than a discernible medical disease. The Cleveland Clinic emphasizes that conditions like conversion disorder are real mental health conditions, not intentional or imagined symptoms. So, what's happening? One way to think of it is the person's psychological distress is being converted into physical form. Unresolved stress, emotional conflict, or trauma might manifest as a paralysis of an arm, or chronic pain, or non epileptic seizures. The term conversion actually comes from this idea of converting mental pain into bodily symptoms. These disorders are often linked with conditions like anxiety or depression. For example, someone with intense anxiety might constantly feel sick or in pain. It's also a diagnosis of exclusion, meaning we typically conclude it's a somatoform disorder only after ruling out any and all medical causes. In summary, somatoform disorders are when the mind's distress plays out through the body. The patient isn't in control of it. They truly feel the symptoms. This differentiates it from disorders where symptoms are faked, which we'll clarify soon. As EMS professionals, we need to approach these patients with validation and care, just as we would anyone in distress. Let's go through the key types of disorders in this category. Somatic symptom disorder, SSD. This is a broad condition where a person has one or more physical symptoms, like pain, fatigue, or other complaints, that persistently worry them. The hallmark is disproportionate anxiety and thoughts about these symptoms. They might have a mild symptom but believe it's something life-threatening, or the symptom could be more significant but their reaction to it is extreme. They often repeatedly seek medical help. For example, someone might have ongoing stomach pain that no doctor can find a cause for, yet the person is highly anxious, constantly checking and convinced something is seriously wrong. In older terms, this would cover what used to be called somatization disorder or certain pain disorders. The important point: their symptoms are real, but their focus and anxiety about them is extreme and debilitating. Illness anxiety disorder. This used to be known as hypochondriasis or being a hypochondriac. In this disorder, the person may have few or no physical symptoms at all, but they are obsessed with the idea of being seriously ill. Every minor ache or normal sensation might be interpreted as a sign of cancer, a heart attack, or another severe disease. Even after medical evaluations find nothing, they struggle to believe they're healthy. These patients often bounce from doctor to doctor, or in our context, they might call EMS frequently because they feel like something is terribly wrong. I just know I have a serious disease. Their anxiety about health is chronic and consumes their life. Conversion disorder, also called functional neurologic symptom disorder, this is a fascinating condition where the person has neurological-like symptoms, such as seizures, paralysis, blindness, trouble speaking, or numbness, but no neurological cause is found. It's as if the brain's emotional turmoil is converting into neurological symptoms. For example, someone might suddenly become unable to see, psychogenic blindness, or experience what looks like a seizure, but all testing, brain scans, EEG, etc., is normal. We will discuss this in more detail soon, as conversion disorder is particularly relevant to EMS. Think of patients who appear to have a stroke or seizure. For EMS professionals, it's useful to know these distinctions. But in practice, when someone has unexplained symptoms, our initial approach doesn't involve accusing anyone of faking. We treat what we see. Only later, after medical evaluation, might it become evident if something was factitious or malingered. The focus for somatoform and conversion disorders is that the patient is genuinely experiencing symptoms without a physical cause, meaning it's largely driven by psychological factors, even if they themselves may not realize it. Conversion disorder is one of the most noteworthy somatoform disorders for EMS providers. It's officially termed functional neurological symptom disorder nowadays, emphasizing that the nervous system is functioning in a way that produces symptoms without an organic disease. In conversion disorder, a patient experiences what look like neurological problems, but no medical cause is found. This can include seizure like activity, convulsions, without any abnormal EEG activity, often called psychogenic non epileptic seizures, paralysis or weakness of an arm, a leg, or even one side of the body, mimicking a stroke or spinal injury, but with normal reflexes and no injury, blindness or vision loss or inability to speak, mute, or deafness that come on without a neurological reason. Gait disturbances or coordination problems, inability to walk, etc. Typically, these symptoms start or worsen during times of intense stress or emotional conflict. For example, a person who experienced a traumatic event might suddenly lose the ability to move their legs, even though their spinal cord is fine. It's as if the brain converts emotional pain into a physical manifestation that has symbolic meaning or provides escape. A hallmark is that the patient is not consciously controlling these symptoms. They're not pretending. The paralysis or seizure is very real to them. In fact, their brain on some level is causing these physical signs, but it's not under voluntary control. The Cleveland Clinic specifically notes that conversion disorder is not faking or attention seeking, and the patient can't just stop it by willpower. You might hear the term la belle indifférence, a French term meaning beautiful indifference, taught in relation to conversion disorder. It refers to an observation that some patients with conversion disorder don't seem as concerned as you'd expect about their dramatic symptom. For instance, someone with sudden paralysis might appear oddly calm or indifferent about it. However, this is not present in all cases, so don't rely on it as a diagnostic sign, but it's something that's historically noted. For us in EMS, the key is that conversion disorder can mimic acute neurological emergencies, seizures, strokes, etc. We often won't be able to tell in the field if it's conversion disorder or a true medical event. More on that in a moment. So we treat it seriously, but knowing about conversion disorder prevents us from being dismissive or frustrated if the hospital later tells us no cause was found. It reminds us that the patient wasn't malingering. They likely have a serious psychological condition that needs care. Next, illness anxiety disorder, formerly known as hypochondriasis. These patients have overwhelming worry about being seriously ill. Unlike somatic symptom disorder, here the person typically does not have significant physical symptoms. If they do have any, they're usually mild. The core issue is the anxiety and preoccupation with the idea that they are sick or will become sick. For example, a patient with illness anxiety might feel a slight dizziness and become convinced it's a brain tumor, or a cough convinces them they have lung cancer. They misinterpret normal body sensations or minor symptoms as evidence of grave illness. Even after doctors evaluate them and find nothing wrong, they remain convinced or soon start worrying about another illness. The Cleveland Clinic description highlights that even with normal tests and reassurance, people with illness anxiety disorder struggle to shake their fear. In an EMS context, these individuals might be frequent 911 callers. For instance, someone might call an ambulance for the third time in a month for chest pain that has consistently been worked up as non cardiac. Each time, they're terrified it's a heart attack, despite prior negative results. Or they might call for headaches, fearing an aneurysm, etc. It can be challenging because each time we still have to treat the complaint seriously until proven otherwise. After all, one day it could be real. These patients often doctor shop and have thick medical files of tests that show nothing. They aren't doing this to get attention or pain meds. It's truly because their anxiety about health is uncontrollable. They often bounce between believing they have different diseases. Last month it was my heart, now I'm sure I have a brain tumor. This chronic cycle can severely affect their quality of life. As EMS providers, we should recognize the pattern if someone is a repeat caller for vague or shifting complaints with a history of extensive negative workups. It doesn't mean we ignore the call. Rather, we provide reassurance, perform our evaluation to ensure nothing acute is happening, and then transport if appropriate. Our communication is key. We want to avoid sarcastic or dismissive comments like, oh, it's just you worrying again, and instead be empathetic while sticking to facts. Your vital signs are normal, and we aren't finding signs of a heart attack right now. That's good news. We'll still get you checked out at the hospital to be safe. We'll cover communication more later. Another key diagnosis in this category is somatic symptom disorder, SSD. This is somewhat of an umbrella for people who do have physical symptoms, unlike illness anxiety, where there's essentially no symptom, but their response to the symptom is extreme. To break it down, the person has at least one distressing physical symptom, which could be anything: chronic pain in multiple areas, GI issues, fatigue, or neurological like symptoms. Importantly, sometimes the symptom started with an actual medical issue, say a real injury that healed, or it might be an unclear ailment from the get go. Regardless of its origin, the patient develops an excessive focus on it. They have intense anxiety about their health, constantly worry about what the symptoms mean, often fearing the worst. They may check their symptoms repeatedly, research excessively, and frequently go to doctors for the same symptom. Medline Plus describes that even when tests are normal and providers reassure them, the extreme worry doesn't subside. For example, someone with SSD might have ongoing headache and fatigue. They've seen multiple doctors who found nothing serious, yet the patient remains convinced something was missed or that it's disabling enough that they can't work or function. They might become very disabled by their health concerns, missing work, avoiding activities, and essentially their life revolves around the symptoms. In EMS, an example could be a patient with chronic abdominal pain for years. They call 911 because the pain today is severe. You find normal vital signs, and they mention they've had countless scans showing nothing. However, they appear very anxious and in real distress about it. Another example, someone with long term back pain who has had surgeries and is on medication, yet calls EMS frequently when the pain flares, expressing fear that maybe it's something the doctors haven't found. So, SSD patients truly feel physical symptoms. They are not imaginary, but their emotional response is amplified. The worry and behaviors, doctor visits, avoiding activity, are out of proportion. It's like their mind is stuck in a loop of concern that magnifies the impact of the symptom. Our approach to them in the field is similar. Treat any acute issues, like give pain relief if indicated per protocol, and understand that reassurance alone often doesn't calm their fears for long. They typically need ongoing medical follow up and often therapy to help manage their health anxiety. To recap the differences so far, in illness anxiety, the fear of illness is the main problem, with minimal symptoms. In somatic symptom disorder, there is a physical symptom, or several, causing the fear and excessive response. And conversion disorder is a specific neurologic looking symptom likely tied to stress. All fall under somatic disorders and all can intersect with EMS. We will wrap this part up here. Join me in the next section to discuss how these patients present in the field. See you then.